Okay, welcome everyone. Thank you for joining us today. It is 2:01 Eastern Time, so we'll go ahead and get started. Thank you for spending your either afternoon or middle of the day with us today. I'm Melynda Lee, and I'm here with my colleague, Judy Connelly. We are consulting leaders with SimiTree. We're going to be talking about hospice growth today and how to reactivate growth in your agency. So let's go ahead and we'll get started. I'll show you what we're going to talk about after the setup here. We're going to start with some industry updates, what's changed, what's coming. We'll talk about the formula for success. We'll talk about referral partner and territory management, time management, and value proposition. So let's talk about the significant industry changes, and we'll go ahead and kick off with that. I'll turn it over to Judy.
Hello, everyone. Let's tackle some of the industry changes. Now, just the other day, the Department of Justice pushed out a stern warning that they're going to continue to scrutinize what it is that we're dealing with in hospice care. We know the pandemic drastically changed how we function. Some people are out of the office still, some people are in. We see gaps, we see fragmented care and communication. Everybody is making their way through that. And tied to that, based on how we changed our functions during the pandemic, is the fact that we now have staffing shortages and everybody wants to work from home. They don't want to come back to the office. You know, one individual said to me, they expect me to go back to the office now. And I said, and she told me how far away it was. And I said, well, did you live in the same place before the pandemic and drive the same distance before the pandemic? And she said, yes. So it's everyone has reset their life based on what they want to do and where they worked before. Staffing shortages everywhere, no matter where you go in healthcare, it's a challenge. And then multi-generational workforce, what they expect, what they want. They want to be in, out, done, and they do want to do a good job. They want to feel that they're valued. And some of the other individuals in hospice, sometimes refer to them as legacy employees. They've been there a long time. They function very differently. They see the word as productive performance a little bit differently than your multi-generational workforce. The younger individuals typically want to get that work done, uploaded, and the documentation done. I've been around for 30 years, so sure, I started out functioning different. Competition, lots of mergers within our organization and within the healthcare environment. We'll talk a little bit about we have to be aware of our healthcare environment. We're at the end of the food chain when it comes to healthcare. Everybody expects us to shore up all the gaps and fragments that occurred in healthcare. So mergers and acquisitions are going to continue to impact us. Everybody above us, from the hospitals to the doctors to nursing homes, assisted living, all these individuals have expectations for us. So we're constantly jumping through hoops to try to make sure that they, as our customer, as well as the patient, we are able to meet their expectations and demands. And then data. I mean, in the early days of hospice, everything we did was intuitive for the most part. I really didn't like data. I didn't want to look at it. We didn't have access to it. But in today's universe, data drives everything. So what does the data mean? What are we going to do to utilize that data in terms of developing a strategic plan? Telehealth, telecommunications, some of our patients don't want it, others want it and expect it, especially if loved ones are out of state. We see that sometimes. Insurance and reimbursement patterns. We know that the value-based insurance design has been extended to 2030. That's a lot of time to collect a lot of data. And CMS has a lot of data, and they're going to use that to design change in our industry. The hybrid workforce and environment, we talked a little bit about that in terms of how you're going to structure your organization. What kind of communication are you going to have? And what does that mean to your employees? If management and leadership is never in the office, and really office or visit staff often are not in the office, but what are the perceptions related to nobody being available? I had someone say to me the other day, every time I call, they wanted to go to voicemail so I don't hear my manager loading the dishwasher. So there's all kinds of perceptions that can impact the well-being of our staff. Changing consumer and referring provider behavior, we see that every day. Expectations are laid out. We have to be somewhat consistent in our practice, but we're always learning how to do a better job at providing service and meeting our quality standards. So what else are some of you seeing? You can enter that in the chat if we didn't touch upon something that you're really struggling with or that you're seeing in your area. Other things related to impact at the agency level, and Melynda and I may tag team each other throughout this presentation. Lots of expectations regarding hospice growth nationwide. I mean, hospices are merging so they can continue to grow, so they can have great efficiencies in practice. And then significant downturn during and towards the end of the pandemic.
And
Ongoing. Yeah, go
I'm
ahead.
sorry,
Melynda.
Judy. I'll jump in really quick. You know, a lot of what we're seeing in the marketplace, and many of you are probably experiencing, was a surge in hospice growth in 2020 and into 2021. And then now there's a significant downturn. And that's a nationwide challenge right now, which is one reason we're here today. So sorry to interrupt. I just wanted to make sure that everyone knows you're not alone. This is a widespread challenge.
And then that increase in staffing shortages, I mean, it doesn't really matter where we go, we're finding that. So we need to get creative. Hospice is a team dynamic. We're regulated as a team. Who can I teach on my team to fill some of these gaps? We certainly have to follow licensing and so forth. But there's some opportunities to look at the talent that we have and how they can fill the gaps to meet our patient family needs and some of our customer needs. Burnout, we hear about it. Sometimes we refer to it as churn and burn. Length of stay is short in the vast majority of hospice companies. So you're admitting people, and you know the expectation when you look at the numbers, it looks like you've admitted all these patients, but you actually had an equal amount of deaths or possibly more. And palliative care sometimes impacts that. We know palliative care is a benefit to our patients and our families. But in some environments, it may impact that short length of stay. How do we get in? What kind of conversations do we need to have? How do we facilitate longer length of stay, which can impact the well-being of our staff? They don't feel like they're climbing a muddy hill. And then ongoing demands in the marketplace. What our families need, what they want, what are their misperceptions, and what are their needs in terms of meeting the patient family needs. And Melynda may see more of that than I do because she's constantly embedded in data related to marketplace.
Yeah, the demands have changed in terms of the expansion and contraction of agencies through mergers and acquisitions. Consumer demands have changed, and the way referral partners do business has changed as well. You know, the pandemic changed the way that we are able to engage and the way that our customers want to be engaged. So, and of course, there's more information than ever before available to the marketplace. So they're making decisions and have preconceived ideas too about what they want, and they want to be involved in healthcare decisions.
I love this slide. I believe this is from Johns Hopkins, some research they did. And this is a great opportunity to look at the value of the dance between operations and development, because this kind of relates to the concept that I mentioned that we're at the end of the food chain when it comes to hospice care, right? Look at the things that have occurred in the year of the life of a patient. How many nurses? They don't remember everyone's name. They can't remember where they last were. Occupational and physical therapy. They're lucky they're on 22 meds and not 44. Social work. The roles of social work vary from industry to industry. Was it a discharge coordinator? Was it a discharge planner? Was it somebody that was part of a multidisciplinary team? We're blessed in hospice with the ability to utilize social workers in a way that few other industries do. Home care agencies, was it nursing? Was it skilled? Was it therapy? Outpatient therapy, inpatient therapy? What type of community referrals? What are my social determinants of care, social determinants of health, often referred to interchangeably? What do I have going on? Who are the people coming in and out of my home? And how overwhelming is it? Same thing with nursing homes. Was I in there for skilled? Was I in there for rehab? How did that go? Did I hope to stay longer and I only had X amount of visits or days in rehab? And then 6 weeks of skilled nursing care. What happened while I was in there? What was my experience? And so often we're stepping into the middle of this. Hospital admissions, any recent trips to the ED, you will find that they weren't pleasant. Home care and then private duty could be mixed in here, and then countless doctor and clinic visits. So these are all possibilities. And then I always like to say, just add a sprinkle of family dynamics to this circle, and you can see why so often when we get our patients, they're profoundly overwhelmed. They're exhausted. They're confused. They don't know what day it is, and we can completely understand why they don't. And now we're adding another dynamic by not only introducing care, we now have to explain a whole different insurance benefit, which a lot of people don't quite understand. When you go in the hospital and they admit you, they're not reviewing your insurance benefit, are they? But when we go in, we have to take the time to introduce them to an insurance benefit that has guidelines and restrictions. And then we are supposed to, based on CMS standards of practice, ensure that they have a clear understanding of what that is. So you can see by the time our patients get to us, it can be extremely overwhelming and chaotic.
Thank you, Judy. All right, so let's talk about the proven strategies for success. So how do you reactivate your hospice growth? So starting out, and some of you may have heard us say this before if you've done any of our training, there are two ways to increase admissions. There are really only two ways. And the first is to compete for referrals and win. And the other is to expand your referral partners' use of your services. So this is really about market share and market penetration, and you need a solid strategy that addresses both. The fastest way to grow, of course, is by protecting and nurturing your existing accounts where you're getting business today, but you also need to have new business in your strategy. So check your strategy, see what where your business is coming from. You should be doing that every quarter anyway, and looking at your referral and admission trends by account, by referral source. And that's going to tell you where the peaks and valleys are. And that way you can update your strategy to ensure that you're getting to your accounts who may be seldom referrers, and then of course your frequent referrers. And then you want to be sure that every week you're seeing your active referrers, your biggest referrers, because you want to be sure that you're protecting them. And that's where expansion is going to occur as well. So these are the 3 steps we recommend to reactivate your hospice growth strategy. First thing you want to do is conduct a market scan. That's where you have to start. And you really, again, should do this every quarter because things change rapidly. The second, and we're going to break these down, is to evaluate how your staff spends their time. So how your staff spend their time really is going to be an indicator of whether or not you have training gaps, whether or not you have the right number of people, whether or not they're going to the right places, doing the right things, and they're looking to leadership to give them guidance on that. So this is a very important part of your strategy. And you can have a great strategy, great data, great plans, but if your staff isn't able to execute effectively and efficiently, it won't matter. And then the third part is to define your value proposition. So our industry is really great, especially with hospice. We're really great about telling everyone all the great things that we do that we're really proud of, and you should be. You impact people's lives every day. However, we need to think about the customer journey. How are our customers making decisions? We know they have choices. Expectations are high. And are we making it easy to do business with us? That's really the differentiator. So you want to make sure that you're talking about features and benefits. Why does it matter to the customer, whether they're a referral partner, potential referral partner, or a patient and family? Why does it matter? Why would they want to do business with you over any of your competition? And that's how you develop your messaging. So let's break this down. We'll start with data. So you want to make sure, and we talked about the data a little bit earlier that's available to you, and we have better data, better access to data now than ever before. Those of us who have been in the industry a long time, like Judy and I have, we're used to working with either no data or data that was 4 or 5 years old. Now we have data that is updated every quarter and available to the marketplace. You want to make sure that you're looking at your market share and competitive landscape every quarter and what's changed. Who's entered the market, who's left the market, who's gaining share, who's losing share, where do you fit in? How do your quality scores and your customer experience compare with your competition? Judy, if you want to jump in on that, I think this is a very important piece that sometimes gets overlooked.
Yeah, there is a component of this that really aligns with operations. So if we're going to look at our data and we're going to separate out possibly what we're finding and what the issues are, you can often align it with your customer experience scores. Is it a particular item that's just fallen through the cracks? Have I done enough teaching with my patients and my families? Does my staff understand their scope of practice and their accountabilities? They may be aware of this survey, but they may not realize how tremendously they impact that outcome. In some areas, facilities are now encouraging families to get on the compare site and choose for themselves between 3 or 4 hospice programs. So in my region in particular, for years now, the nursing homes and facilities have referred the families to the compare site. And they say, these are the hospices we work with. Please take a look and see who you would like us to have care for your loved ones. So all kinds of things go into that. And your staff have to be educated to what the demands are in your market area, particularly facilities. How are they informed of what the expectations are? Because every facility is different. Often every unit is different, every shift is different, every charge nurse is different. So making sure we align all of that can really facilitate great quality scores, great outcomes, and then that customer service experience.
Thank you. And when you're looking at the market claims data, one of the first places that we always go is to look at how many patients are going home from the hospitals in the area, whatever geography we're looking at, with no post-acute care. And we're looking specifically in this context, we're talking about the Medicare claims data. The national average is 43%. And especially for hospice patients, and we can assume, probably 10% or more of those people could have benefited from hospice. That's really tragic because we're not getting to them for some reason. And that should be part of your strategy. Are we having conversations? Are we helping our referral partners in the hospital get the time to have the hospice conversations? That's where we add value. As hospice providers, that's one of the greatest benefits that you can provide to, especially your hospital partners. And then what can you learn from your own data? So you have data in your own systems, your EMRs, you probably are looking at reports, hopefully daily and weekly. And what does that data reveal? Are you looking at the patients who are not taken under care? Are you looking at the pending referrals? Are you looking at live discharges? And of course, your admissions history. What trends have changed? What's happening? And when you're looking at your pending referrals, you should be talking about them daily and have an action plan for every pending referral, because time is of the essence, of course, with hospice referrals. And we want to make sure that we have a plan to reach out and make sure that care is provided when and where appropriate. And then with our intucts, patients not taken under care, find out why and look at the individuals who are responsible too, because you may have some training gaps. You may have trouble somewhere overcoming objections. So find out what's really going on there. It may be a referral source that you work with who needs to have some support, maybe some guidance when making hospice referrals. There's a lot of intelligence that you can uncover in your own data. So take a look too at your conversion rate. A lot of times, we'll get a call, we'll hear, we need sales training because we need more referrals. And then, I'll ask, well, what's the conversion rate? And we find out it's not really always a referral problem. Sometimes it's an admission problem. What's the challenge? Why are the referrals not getting converted? So look at that. Find out, again, individually, what's happening. Where do you have training opportunities? Where do you have an opportunity to make some improvements, maybe to streamline some processes Again, you want to make sure that all of this is occurring timely. So use that data wisely. And then what does your market data reveal about your account's referral patterns? This, again, you should be doing quarterly. What's changed? Who's stopped referring? Who's referring more than ever and why? This is all information that you need as part of this 3-step plan to be sure that you're capturing all the opportunities in your marketplace. And if you're curious about market data and you don't have access to it today, or you'd like to learn more, drop us a note in the Q&A section and we'll get in touch with you. So, Judy, I'm going to lean heavily on you here too, because this crosses across all functional areas when you look at how your staff uses their time. So, Judy, I'll turn this one over to you.
So as you're strategizing what you're going to do in terms of growth and looking at your market, make sure you interface with operations, because your goals have to align. We can't have pie in the sky numbers when we have no idea how we're possibly going to cover it. Make sure your staff is educated to the word accountability. It's different than responsibility. It's a big word. It's been used more in the last 5 years than ever before. How do they impact our ability to see patients? Look at your staffing. What are your staffing patterns? Can you cover the evenings? Collect data on what is the busiest day, typically maybe Friday. When do most of your referrals come in? After 1 or 2 o'clock? Do you have a goal of same-day admissions? Because almost everybody around you is trying to do that. And then communicate what these metrics mean to your staff. Identify this measure. We are impacting this measure by our ability to see these patients. What is your productivity expectation? Again, who on the team can I use to get into the home first? And I always say, I can teach my mailman how to explain the hospice insurance benefit. I need my nursing time. It is a premium to get in there and do my initial assessment and get these patients on board. So look at the company level, look at your team and the region level. I would assess my areas of performance. Every day I had a report that let me know, because you can have 4 deaths overnight and you can have 6 admissions. And I maybe need to have team members overlap their regions to get in there and do that admission. What kind of pay scales do you have for after hours? Do you have an after hour team? So looking at how you're functioning as an organization, as the hospice, looking at each team, what do they need? How do I encourage them? Do I have them share regions? Nobody really likes to do that. But if you're part of a larger team, we help each other out. And then whenever everybody's drowning and they're, disgruntled and they feel burdened, typically that period of time is short-lived. We need to encourage our staff that we'll get through that. And the care that we provide is the best thing that has ever happened to that person. We want to provide our great care to more people. And then look at the individual. What do they need? Our job is to educate and equip, make sure everybody has what they need and have a clear understanding of their role and their responsibility as it pertains to getting out there and taking care of the patient. So that mutual understanding of this is where we're going. I mean, really, your team should know what your goals and aspirations are, either for the quarter or for the year. Sometimes it's easier to break it into the quarter. Explain to them the environment we're living in. Our teams come to work to do great things. They need to understand why we're asking them to do things. I would always say, I don't lay awake at night coming up with things to make you miserable. I lay awake at night so more people benefit from your excellent care. Look at excuses. It really doesn't help us to make excuses. You never resolve an issue if you make an excuse for it. If you can identify the problem and the cause at hand, that then facilitates great conversation and decision-making. Redirect behaviors. As leaders, we need to do that. We have to facilitate an understanding of the team's accountability and that it's everyone's responsibility. We are not going to blame individuals if something fell through the cracks. We're going to look at why it happened and we're going to resolve the issue so hopefully it doesn't happen again. So all those things related to trust. Look at your IDG meetings. How long are they? If they're too long, I don't need my team sitting in a long IDG meeting. I need them out in the field. Do you have an efficient, effective led IDG so your team members can provide great conversation and great care planning and I can get them out in the field to do those admissions and see those patients. So I can have great outcomes. And really, your staff is satisfied when they do great things for their patients, right? And then team culture. Every team, every IDG, they have their own little unique culture. Everyone loves the way their team is functioning. We need to take the time to look at that. What is the role of my physician? Does my team understand that CMS pretty much tells us what the role of each team member is to be? And educate them to that. Make sure they understand that what they're doing in IDG is central. I call it the center of the universe to us achieving our goals, our expectations, and our vision. Outline all those things, build a team that is hungry to resolve issues and do problem solving, recognize that success, and be patient, kind, and display grace. This is what will retain your staff. These, again, are people who want to do good work, and we don't want them leaving. So all these things really help us grow our ability to provide care to more people in a timely manner.
If you want to wrap up on with any of these, this was kind of
Sure. So legal and ethical considerations. I do use the word ethical a lot when I work with my teams. I think it's important that we realize that we are advocates of phenomenal patient care. And sometimes I align this with the uniqueness of hospice language. Who else does what we do? No one. Who else has the team opportunities that we have? We are regulated. Everybody knows the conditions of participation, and we're obligated to make sure the patient gets the best care at the best time. Again, how do we use our team? We're regulated as a team. We certainly know the scrutiny that we're under. So talk about our opportunity and work with your home health divisions. I always look at the opportunity to transition a patient from home health early and have the conversation often and repeatedly as an ethical obligation to informing all of our patients, home health, palliative care, otherwise, to the opportunity to choose the hospice benefit. It's a little bit of a different twist on philosophy of care in an organization, but I encourage you to look at that. Rehospitalizations are not a good thing for home health. Nobody likes them. How do you interface with your home health division, if you have one, to move those patients to have a greater understanding that their disease is continuing to progress and that when they came home from the hospital, their disease state was not fixed? Same day admissions. We're a breath of fresh air, and if we don't do it, there's another hospice who will. Lots of creative aspects to doing same day admissions. We are the people that our patients and families are waiting for. Look at the length of time you're spending in an admission visit. Who are you involving? Is there somebody going over the insurance benefit before the patient gets home? Make sure you're aligning those conversations. Are you having conversation with your physician or your medical director so you can have an admission conversation regarding eligibility, related, not related? When are you getting your equipment in there? Was it a smooth transition during a really overwhelming time? And then documenting. What did I do or say before? Pardon me. And what kind of post call did I have after I met with my family and or spoke to them about the hospice insurance benefit? Am I anticipating their next need? What's coming next in terms of medication management? All these things are critical to accountability and satisfaction scores when it comes to publicly recorded data. Ride-alongs. Be available to your staff, be available to your marketing team. Operations and marketing and development, we can learn so much from each other. We have to make sure we're not siloed. We have to respect one another's environments. We need to respect all the healthcare environments that we're buried in, because that helps us develop relationships, and then setting those smart goals and following up on them, learning from them, and readdressing them as we go.
Yes. Thank you, Judy. And a lot of what we're talking about here really it cuts across the entire organization. So marketers should be doing their pre and post call plans as well. And we cannot emphasize enough how important it is for leaders and managers to do ride-alongs with their staff. And that's where the magic really happens in terms of coaching and mentoring and training and really knowing what's going on in your marketplace every day as well. So step 3, your value proposition. We talked about this a little earlier. What solutions do you provide that are going to solve problems, achieve goals, and satisfy the needs of your customers, whether we're talking about patients and families or even staff, volunteers, referral sources? Everyone is looking for a solution. So it's our job to be sure that we're always able to articulate whatever that value proposition is to fill the need, the pain point of the people we're serving. So we encourage you to be sure everyone is an ambassador of your organization, that you can help your staff achieve and provide clear, consistent messaging. You want to make sure that your messaging is easy to remember and easy to repeat. What do you stand for? What is your why? This is how you protect your brand. This is how you protect your culture. And be sure that everyone knows what the value proposition is. And the way to do that is to practice. So do this at your team meetings, do this at your town halls, do this at your team building events. Just be sure that you're doing this and that everyone understands and everyone's able to articulate that message.
And don't forget about the volunteers. Every single volunteer is a marketer for you. And then everywhere we go, we're a member of the IDG. So really train your staff to be aware that they represent your organization, really, no matter where they are. More than one person came up and hugged me in the grocery store. I had no idea who they were, but they knew that I had team members that provided loving care to their loved one. So don't forget the volunteers. This should be part of their education. They feel valued. They share in your success. So make sure that's part of your volunteer program.
Yes, from everyone who answers your phone, to your volunteers, to your medical director, and everyone in between. And considering the customer journey is how you do this. So everyone's listening for what we call the WIFM, the what's in it for me. We come into contact with people who need hospice care somewhere between recognizing that they have a need and there are people out there who can help them solve it, and considering who those people are who can solve that. And what we want to do is make it easy to make a decision to work with us. Don't make it hard for people to apply for a job, for people to make a referral, for people to call and find out when their nurse is coming. We want to be easy. The people that we serve, that we care for, that we work with as referral partners, whom we hire, all have enough on their plates. So let's make it easy to do business with us. And that in itself, if you're really good at doing that, is a differentiator. So when we think about who our customers are, we usually typically think about patients and families, right? We think about referral sources, but really everyone you see on this screen should be considered a customer. So this could be, certainly patients and families, but the influencers, people who influence their decisions about hospice care. Employees, potential employees, people that we want to hire or may someday hire. Donors and volunteers. If you're a nonprofit, especially, your donors are your customers, and your volunteers are certainly your customers. They have other choices. So again, we want to be sure that they understand the benefit of engaging with us, and that how we're going to help them solve their problems or what's in it for them. And then, of course, as we talked about earlier, our changing marketplace and landscape, our payers, partners, accountable care organizations, referral partners, and then a lot of other potential audiences, and some we may not have even mentioned that you can think of. That may include potential business partners, that may include mergers or acquisitions, that may just include other community partners with aligned missions who can help enhance the service and care to engage people in your community.
Make sure your team is educated as to what a customer is. In the 90s and the early 2000s, if you referred to a patient as a customer, the staff just about tarred and feathered you. But if you took a complaint from a patient or a family member, you knew they were a customer. So keep that in mind. Internal customers, external customers, The professional boundaries, these are things I can share with external customers. These are things that only have to do with internal aspects and internal processes. And really, anytime we share information with our team members, they almost become a customer. So anyone you're communicating with, anybody you're sharing information with to the benefit of our patients, families, and referral sources, they are in some ways a customer. So it's really important and can change your culture if you educate your staff accordingly.
Judy, I'm going to hand this one over to you, so because we want to be sure that we're checking in with operations.
Yeah, and I just mentioned the word culture. I mean, the beauty of what you have an opportunity to do is as you educate your team, as you equip them, it's very important to encourage and equip. I call those the E's. It's important that they're educated as to their role in growth. So one example I always think of is when you go to a facility, you should have some sort of a tool that outlines who all the major players are. The administrator, sometimes the receptionist, who are the staff on the floor, who are the social workers. Do you keep a data file so your staff knows, what do I do if I go in after 9? What do I do if I go in after midnight? This reduces the stress of both the staff and the facility. This is a dynamic environment doing work in a facility. So what are you doing? How are you maintaining this information? Because we know it's always changing. An administrator leaves and takes 2 or 3 of the team members with her. A new administrator comes and brings 2 or 3 team members. And guess what? They used a different hospice where they were. So how are you going to adjust to that? What are you going to do to educate your staff to be patient and kind in a very dynamic arena? So think about those things. We all play a role in increasing our patient base because why? We do great care. We want more people to benefit from the care of our team. And how often are you communicating, not only internally, but externally? How are you managing? Sometimes I refer to the death of a patient. Are we expecting one individual to be able to reach out and tie up all the loose ends of a death? You know, calling, if you have to call the coroner, the DME, the pharmacy. Are you doing that by email? Are you expecting your staff in the field to juggle all of that information whenever they're trying to take care of patients? It's a golden opportunity to call a physician's office, especially the attending, and thank that team over the phone for not only the patient, but reminding that team that hospice was able to provide fantastic care there at the end of life. And that patient was grateful that that physician referred them to hospice at the time they did. Now we know we wanted them earlier, but you don't say that. But there's so many opportunities to communicate with individuals that can really facilitate the awareness of we're making this extra phone call because in the end, it will benefit us and the patient or family in some way. Identify your accounts. What are my prospects? We have all worked in a facility where we're just feel like we're beating our head against the wall, but we need to listen. There are times when you can actually do a performance improvement plan with the facility. It really aligns your efforts. It shows a tremendous degree of respect. The facilities have their own struggles, staffing, regulations, surveys. The more you know about the facilities and what they have going on in terms of their demands, the easier it will be for you to say, I can help you with that. I can take that patient. I can reduce your phone calls. I can reduce your burdens because I'm going to be interfacing with the family. So there's opportunities there as every staff member floats through that facility. Educate your staff to keep their eyes and ears open. And is there an opportunity for your physician or nurse practitioner to interface with the physician in the facility or the nurse practitioner if they have one? And then we all know that social work is underutilized in our industry in many, many cases. Social workers, they speak their own language and they know the burdens they have. So identify how you can utilize your social worker to make things easier in a facility and support the facility with the dynamics of family demands and family situations. And then what's working? Why isn't it working? Let's look at the reason. Let's not make excuses. Let's support our team when maybe their eyes are rolling because they don't feel like there's one more thing they can do to keep everyone happy. But let's come up with a plan that's short, sweet, efficient, and effective, and let's share it. And then I use the word pilot. Not everybody likes the word pilot, but pilot it. See if it's effective. If it isn't effective, then back it up a little bit and see what you need to do. And make sure your staff understands that part of our culture, part of our dedication is to understand that each facility, yes, they are going to have a different expectation, just like many of our families do. So there's a lot of opportunities in working with your staff to educate them and support them and move through that accordingly.
And also be sure this is a time to use your data too. When your operations team tells you they don't have enough clinicians in a certain geography for your marketers to say yes to referrals, that's the time to collaborate. That's the time to look at your data, where are your greatest opportunities in terms of referrals, as well as where you do have staff. And that means you may have to change up some territories. That means you may have to change up your marketing strategy. But again, back to how are your people spending their time? Make sure that everyone's able to spend their time where they can say yes. And Judy, thank you for sharing those strategies in terms of being able to say yes and provide the greatest benefit possible to help our referral partners.
Sure. That's really part of the fun part of the day, watching all that happen.
Yeah. Which is a great way to come to a close here. We want to make sure that we're always talking about the benefits to our customers. Again, any of the customers on the graphic that we showed you, where you have a lot of different customers you're serving, a lot of different customers that you're engaging at any given time, make sure that we're helping them understand, and we have to connect the dots, what's in it for them, how can we help them, how we're going to make an impact in their lives, how we're going to reduce their stress, save them time and money, and make their lives easier.
Yeah, I love this slide because I don't think we always realize the uniqueness of the hospice benefit. And I encourage hospices to use the language in the benefit. What's very unique about us is who else looks at prognosis? No one. Trajectory, we have to bring the crystal ball. Who else uses the language such as eligibility, criteria, electing the benefit? So one of the greatest things about benefits for anybody we're working with is just look at your consent form and your election of benefit. Look at the insurance benefit itself. We have multiple gifts in hospice care. We tend to take them for granted because it's what we do every day and it's what we love. Our ability to provide social work support in a home, no one else gets to do that like we do. There may be social work and home health, and each of them have 150 to 180 patients. We're fortunate to have the gifts and the knowledge base of social worker and spiritual team members to really boost the opportunities to provide care in the home. So when you're looking through your consent forms and or your election of benefit, depending upon how you have them structured, there's a lot of WIFMs in there. This is what's in it for you. We're taking care of the unit of patient and family. We will be covering the expenses of related DME. We will be covering the expenses of medications. We have a team visiting you. One of the things that the government established in using that structure of insurance coverage is they designed a team, believing that that was in your best interest as a patient and as a family. And hone in on that concept of identifying all the gifts of the hospice insurance benefit that no one else gets to do. As you're teaching your staff this, it really encourages that concept of we are unique, we are a culture, we are focused on great things that we get to do for our patients and our families. We don't often take the time to look at the outline and the requirements of the hospice insurance benefit and all the different components of it as truly things that we can do for them, and it's all about them. This benefit was designed for you at a challenging time in your life, and it's the best thing that can happen to you at possibly the most demanding time. So think about those different things. Think about your team. How can you frame that to really facilitate teaching that gets the buy-in that you need from all your team members?
Thank you, Judy. We do have one question about Hospice Compare and other ways to communicate improvement in the provider rather than Hospice Compare, which there may have been some timelines that didn't quite line up with some of the improvements.
I think when you're looking at the 5 stars now, the other thing I can get my soapbox out on, I don't know if you want me to, is service intensity add-on. There's a tremendous confusion in the hospice environment regarding hospice visits last day of life, which is part of our quality measures, and the opportunity to provide service intensity add-on care. I try not to use service intensity add-on visits because then most staff members make a visit, 35, 45, 50 minutes. The opportunity CMS has given us, and we want to use it so they don't take it away, is the last 7 days for an RN or social worker to be in the home for up to 4 hours. You know, when they reduced our payment after, 61 days forward, they said, we have enough data to indicate that really what's best for the patients and the family is that you, hospice, are in the home more the last 7 days of life. So utilize that. IDG, perfect time, daily huddles. If you're hearing that somebody's near the end of life, there should be a plan of care of who is going in, how long they're going to be in there, and what are some of the opportunities. Social work has a huge opportunity for service intensity add-on care. So when you're looking at market data, outcomes, quality measures, you have control over those activities, hospice visits, last day of life, and service intensity add-on. And what I have found over time is it's a real culture shift for people to realize that service intensity add-on is not only a tremendous opportunity to increase and boost our outcomes in terms of quality and how our patients and families benefit, it is an opportunity to garnish a little bit more revenue. And yeah, we're all short-staffed. Again, look at your team, how you're utilizing them. How can I get the social worker out there? There's more opportunities in terms of what's my life going to be like after my loved one dies. Oftentimes, by the time we get near the end of life, most of their symptoms have been well managed, unless there's exacerbations. So I am hoping that answered part of your question. But looking at your activity as a culture and how you drive your team through IDG, admissions, conversations, daily huddles can really impact your outcomes and what other individuals are looking for when they get onto the compare site. And I mean, really, we rub elbows with all kinds of competitors. They know what our measures are. Mm-hmm. So talk up your measures and utilize that to educate your team.
Yeah, and again, lean on your internal data. Mm-hmm. That way you know where it came from, it's fresh, and you can tell the story. So that concludes our program for today. We're sharing our email addresses here if anyone would like to reach out and connect directly. I also have, for anyone who put information about contacting you after today, I have that information as well. But if there are no other questions, then Judy, thank you. Thank you to everyone for being here this afternoon. We hope to hear from you, and we'll look forward to talking with you soon.
Yeah, be safe out there.